Croeso cael Amy a'r tîm. This is the fourth in the series of public accountability meetings with all health organisations, which I'm hosting with the Welsh Government team and today with the Powys Teaching Health Board. So welcome to you all. My suggestion is there's quite a lot of us in the room, so rather than go around the room introducing ourselves, perhaps the first time each of us speaks, we can briefly introduce ourselves. As you can see, the meeting is being live streamed to the public, and we have translation of facilities available. So please do feel free to contribute in Welsh or in English, and people will be able to have that translated. Diolch yn fawr i chi. Thank you for the evidence pack which we've received, and we have an agenda which covers 4 areas today. One is in relation to finance and planning, then in relation to access to healthcare services, then in relation to services adapting for the future, and then lastly, how the board's activities and operations are being run. In the evidence pack, of course, there's assurance in relation to a number of those areas. So we will be focusing today on those areas where we're looking for further assurance. So sometimes that'll feel like we're discussing the challenging things rather than the things which are going well. And that doesn't mean that we'll give every item on the agenda equal weight. But there is obviously an opportunity for you to set out the board's position in whatever way you like in relation to each of those items. So an opportunity for you to highlight what's going well as well as some of the challenges. I will raise in the session today some, as I have with other health boards, items that have been raised in correspondence with me from the public, so that their priorities are being considered in the discussions that we're having as well today, as you would appreciate. I think as we go to each of the 4 items, it will be very helpful at the start, if somebody from the health board could give a brief statement outlining the position of the board in relation to that topic. I would ask that is brief. I'm happy to help timekeep, prefer not to, but if we get beyond 4 minutes, I will just say, because I think it's in all our interests just to have an open conversation about the position. So hope you appreciate that, and we'll then ask questions as is appropriate. Before we get into the meat of the agenda, is there anything you'd like to say as chair of the board?
Diolch ysgrifennydd y cabinet, a braf iawn ydi cael y cyfle heddiw I drafod ein perfformiad efo chi. Mae gennau ambell I sylw just I gychwyn ein trafodaeth os gallai. I've had the privilege of serving as chair of Powys Teaching Health Board for 3 years, and during that time, invariably, I've been inspired by the impressive support and care provided to patients day in, day out by our diligent, conscientious, dedicated staff. And I think that's where I want to start our conversation today. Also during that time, we've brought stability to our board, and that we benefit from the rich breadth and depth of expertise, of knowledge and of experience of board members. We focus very sharply on modelling and shaping a values-driven culture. Compassionate leadership starts with me and us, and it ends with me and us. And what that enables is for us to effectively scrutinise within an atmosphere of mutual respect and support. I'm also very grateful for the positive and constructive working relationship that Hayley and I continue to build between ourselves as chair and chief executive. Of course, Powys has a deeply rural context, and that shapes everything that we do. It determines the very distinctive health needs of our 133,000 population scattered across 1/4 of the landmass of Wales. And as you know, we have no DGH, and 50% of our budget goes on what we commission and what not from England and from Wales. And that significantly affects the choices available to us when we develop our strategies and plans. We have provided, as you said, an evidence pack, and that seeks to paint a picture of our priorities, of our achievements, and of our risks. In our delivered services, we don't have anyone that waits more than 104 weeks and 52 weeks for treatment and outpatient appointments. By the end of this financial year, we will have reduced our spend on agency staff by 1/3. Our aspiring nurses programme and our recruitment of internationally educated staff are sources of encouragement for us as a board. Our vaccination uptake is among the highest in Wales. But we do have fragility in some services, such as mental health, the sustainability of primary care, and access to dental services and some therapies. We work very closely with our local authority and other partners, but our delayed pathways of care are unacceptably high still. However, the length of stays has shown a marked improvement. We are in level 4 escalation for finance, strategy and planning. And as a board, we take that very, very seriously, and we are giving it concerted effort. But we do that in a balanced way so that we minimise the risk to our level 1 escalation in all other domains of the escalation framework. We're acutely aware that our financial position has deteriorated. We understand why that is, and we're putting in place plans that will, over time, remedy that position. We have a route map to sustainability, and that route map has 3 dimensions. First, our transformation programme, Better Together. And next year, we will begin consulting on options in phase 1. 2, we have a refreshed approach to commissioning. And only in September of this year, the board approved a new strategic commissioning framework. And 3, our productivity and efficiency improvements. And yet again this year, we will deliver an exceptionally high level of savings. I just want to assure you that the board understands the critical importance and the urgency of these matters. I believe that we've demonstrated that we can grasp nettles and that we're ready to make difficult decisions. We have made difficult decisions. And finally, if I may, I want to assure yourselves of our ready cooperation. As a rural health board with no DGH, we are enthusiastic about developing exemplary rural healthcare, predicated on the principle of community by default, where prevention, early help, care close to home are germane to our transformed model. And that will be increasingly evident in our 26-27 integrated plan. Thank you.
Diolch yn fawr. And there's a lot there which we will want to discuss over the course of the next period that we have together. Dylech chi ddechrau gyda sefyllfa ariannol. Let's start with, as you mentioned, the escalation in relation to finance and planning. And before we get into a discussion on some of the detail, does anybody from the board want to set out your position, Carl?
Sure. I should perhaps just give the apologies. Unfortunately, our chair and vice chair of our finance and planning committee are not able to be with us today, but really pleased that Steve, our independent member for finance and chair of our audit and risk committee, is with us, and he's going to introduce this part of our conversation.
Diolch yn fawr.
Diolch Cadeirydd, Prem Da, Steve Elliott, as Carl just outlined, and I'd like to give an overview of where we stand on finance planning and escalation. Our financial position remains challenging. We forecast a deficit of £28.3 million for this year, with an underlying deficit of £42.1 million. We know our main drivers are commissioning of secondary and specialist care, which is a complicated area as we operate across both NHS Wales and NHS England systems, as well as continuing healthcare, pay costs and private mental health placements. At month 7, we are £2.9 million overspent against this plan, which is largely due to unplanned cost pressures of an NHS England tariff increase of 13%, as well as higher national insurance contributions and forecast JCC overspend. Our savings shortfall is broadly being covered by operational underspends as linked to our enhanced group and control arrangements. On savings, our target is £23.1 million, equivalent to 6.3% of our allocation. Thanks to the efforts of our dedicated staff, we've achieved £18.2 million so far, leaving a gap of £4.8 million. Workforce and medicines management savings are on track, but CHC, commissioning and private provider costs remain difficult. Building on our agreed joint strategy, our clinical services plan is progressing through the Better Together programme. Phase 1, adult physical and mental health community services, is well advanced, with engagement complete and options appraisal underway. The early transformation wins, including more efficient and effective use of staff and space resources, will be included in our integrated plan for 26-27. A strategic assessment of planned care and diagnostics in Q4 will also inform our plan. Our integrated planning for 26-27 is well underway, and this includes the development of our route map to sustainability. In terms of escalation, we remain at level 4 for finance strategy and planning, with all other domains at level 1. An external review is underway to review and help us consider how we strengthen financial controls and address the cost drivers in commissioning and CHC. We are very open to any areas of improvement and looking forward to digesting and responding rapidly to the external report when it becomes available. Meeting our legal duties in finance, as well as quality, safety, risk and governance, are very important to us as a board, and we will continue to make a balanced decision across all of these domains as we move forward. So in summary, while financial recovery remains our most pressing challenge, we are delivering improvements in access, quality and infrastructure. Our focus now is on finalising our route map to sustainability, closing the savings gap, progressing better together and therefore maintaining momentum on transformation.
Sure. Thank you, Steve, for that. Carl, so obviously it's been a difficult 12 months for the board, and the deficit is growing as you and as Steve has just outlined. And I can see the general direction of travel which the board is thinking about, but I'm interested in this year what specific actions the board has taken. And I'm just conscious that the savings plan was agreed in month 6 and we're in month 7. We're just past month 7. So is there anything which you take from that? Could that have been agreed sooner? What specific actions have been taken this year that you feel have made the biggest contribution?
Yeah, I'll ask Pete to come in on that, Cabinet Secretary. I think the point that I would simply make in introduction is that as a board, we are regularly, continually and fully cited on this position and on that in our informal development sessions, but also through our committees and more formal routes. So I just wanted to give you the assurance that from a governance perspective, we are very, very keenly involved and overseeing that. But as for the operational detail, I will turn to Pete, please.
Yeah, thank you. Pete Hopgood, Director of Finance. So we set ourselves a saving target 23.1 million early on in the financial year. We're currently on track to deliver 18.2 million as Steve has described. At the moment, within our position, our operational underspend is offsetting that saving shortfall, but we do not have enough to cover the unplanned pressures within our plan. So the target was set very early. We monitor our progress on a regular basis. Our delivery against that target has grown month on month, and currently we're at 18.2. Those actions continue to try and close that gap, but we are facing pressure in relation to private providers for mental health and LD, in relation to our commissioning expenditure, and also the Joint Commissioning Committee overspend.
So what, if I may, Carl, what would be the biggest contributors in terms of the steps you've taken this year in terms of managing those costs which have got you to where you are now?
In terms of the areas?
Yeah.
In terms of the areas. So we've summarised the areas in our information against the Value and Sustainability Board key areas. Our number one area of improvement has been in relation to our commission services position, where we've taken strong action to set clear targets with the aim to commission within our resources. That's been very challenging and taken a lot of effort by the Health Board to do that. Prescribing is another area of significant achievement, whereby we've delivered £1.7 million worth of savings in that area. And then workforce. Our action around reducing our use of agency has seen a great deal of progress. The number of hours we were using on average for all agency month on month a year ago was 14,000 a month. That's now down to 7,000. Still some way to go, still some improvement to be made, but significant achievement on this basis. And at the moment, our agency reduction is circa 35%.
Yeah, I saw that. I know the check-in and how we want to come in, but just on that point, I can see the controls that have been put in relation to managing agency spend, which I can imagine are making a positive difference. I was interested though in some of the strategic thinking behind that, as well as the cost control element of it, because what is the board looking to do to make that pressure on its operations less acute? So I understand there's a cost control element to it, which clearly is having from a financial point of view, a beneficial impact. But what is the board planning from a strategic point of view to make reliance on agency, less significant in the longer term? Because that's a strategic shift, isn't it? That's needed as well as a cost control shift.
Yeah, perhaps I could bring our chief executive in on that, Jeremy, who may well also want to bring in Deb, our executive director of people and culture. Okay.
Yeah, thank you. I think in terms of the work that we're undertaking, particularly around our commissioning activity for acute services, the first primary focus for us is what can we do in terms of primary and community mental health services within the county. So Carl mentioned about community by default and the need for us to actually protect that capacity and ensure that we do more. So some of the examples that we've been working on is we've got good outpatient facilities in Powys, and we've developed a number of services locally. For example, wet AMD, nurse injectors, doing that within the county, stemming the demand for acute services. That's just one example, but we've also got examples around orthopaedics and the work around musculoskeletal services to actually, again, impact on acute service use, as well as community cardiology, some examples. But we do need to actually put in place a greater emphasis, particularly on referral management. So that is a key priority we've set in year and going into next year, to see how we can actually look again around clinical referral optimization to make sure we're stemming demand on acute services. I think the work we're doing as well around population health, early health and support, and the focus on wellbeing is really important. We know in Powys we've got an ageing demographic in particular, and if you look at the potential demand looking forward, it is not looking pretty in terms of the increasing demands on services. So we've been focusing within the Regional Partnership Board and with the Public Services Board on the actions that we can take to really keep people well in the first place. And an example of that, going back to early years, is for 4 and 5-year-olds, we've had a focus on healthy weights and trying to impact as a whole system on obesity rates for our 4 to 5-year-olds. And we've seen there's been some reduction through the active work that we've undertaken there.
Just on this generally, I want to come on for quite a bigger conversation about some of the community by default, because I think there's a particular characteristics as a board which provide an opportunity for you. But just if you wouldn't mind on the agency point specifically, what is the strategic shift which the board is planning on making there so that there's less pressure on that budget generally?
Yeah, so I will ask Elaine perhaps or Deb to come in on this point specifically, but we have undertaken substantial work. Last year we put in place some temporary service changes, which has helped us to focus our beds, in particular to make sure that we've got better assessment in terms of ready to go home individuals, as well as the rehabilitation focus in 2 of our sites. But we've been doing a lot of work around the model of care, and perhaps Deb or Elaine would like to come in and describe that.
Thank you. Thank you, Cabinet Secretary. In terms of the big strategic thoughts and planning, for us, we've done a considerable amount of work on phase 1 of the Better Together, where we've looked at the demand and capacity modelling, workforce modelling and financial modelling. And what that leads us to is a focusing on the number of beds that we will need into the future and the position of those beds, so where they are across our sites. That in itself will be part of the consultation that the Chair has just shared and will go out September next year. So that's the big strategic driver. In terms of the the improvement that we've had in year on agency, big focus on community wards, significant focus there. There is more to do on our mental health services, and we've got a set of actions around that, including further internationally educated nurses to arrive, further overseas doctors to arrive, healthcare support workers, but we need to progress on that.
Okay. Should we just, Elaine, do you have anything to add, or?
No, I think the main focus, Elaine Lawson, I'm the Director of Primary Care, Community and Mental Health. The main focus from an operational perspective is to transition from the use of agency staff into substantively recruited staff. Deb's already given some detail around that. I think that focus has come both in terms of further concerted effort to recruit specific professionals, but also diversification of professionals. So we've looked at that particularly from nursing. We've looked at the rosters and the way that we're operating wards in particular. We're now transitioning our focus into looking more at our community services as well, and our integrated community teams.
Jacqueline, I think in your
Good afternoon, I'm Jacqueline Totterdale. I'm the Director General for Health, Social Care and Early Years and Chief Exec of NHS Wales, possibly the person with the longest title. So I just wanted to pick up a little bit more on the commissioning bit, if I may, because actually you have quite a lot of power in your commissioning budget, particularly outside of Wales. And I'm just wondering how much time the board spends on how you can commission more strategically in order to get a different outcome from the one you've currently got with your English partner. So I'm just wondering how much actually you can really use your Welsh pound in a different way, and how much strength you feel you have in order to do that.
So if I just initially, Jacqueline, just to assure you that as a board, again, we are very closely sighted on this, and both on the improvement that we've already made, but also on the journey that we still need to travel. So I think I said in my opening remarks, we have just in September adopted a brand new strategic commissioning framework, and that will has already begun to shape how we commission now and into the future, which, as you say, is about how we use every pound available to us and where we spend it and the value that we need to get from that. But I'll just ask Nicola to come in and offer some operational detail in answer to
I suppose what I'm looking for is some tactical, where are you tactically in that?
Sure,
That's what I'm trying to get to.
Sure.
Yeah.
Nicola.
So I'm the Director of Planning, Performance and Commissioning, Nicola Johnson. So as the Chair has said, we developed and the board has approved a strategic commissioning framework in September, but that's not starting from scratch. So in terms of being a more strategic commissioner, we're building on the work that Hayley has already referenced in terms of changing our pathways and demand management for dermatology, cardiology, and we launched a demand management scheme for MSK across all our English providers on the 24th of September, which has already seen early results in terms of reducing the number of referrals into those providers for those high cost specialties and getting the patients to the right places to manage their symptoms.
Is that on the basis of the framework, the new framework? Is that one of the early consequences of that, or was that separate?
We were doing that anyway. Okay. That's already in our annual plan for this year. You'll see in our annual plan for this year that we were focusing mainly on our two highest cost specialties into England, ophthalmology and orthopaedics, and Hayley's also described other work that we're doing in ophthalmology. They were already in our plan for this year. Our plans for next year will identify the further developments of our strategic commissioning implementation plan based on the framework, which will be around our tactical elements around our contract design, pricing and other things that we know we can do, which are already laid out in our commission intentions that we've already shared with all of our providers. Further demand management, accelerating orthopaedics, but we will be developing in Q4 a business case for referral optimisation at scale across our top 10 specialties. We know that we've learned a lot from the actions we've taken this year and the development of the strategic commissioning framework. We know that's really important to us. We know that's good quality for the patients as well as better value for money. And it's evidence-based, it's good on outcomes, it meets population health. As I think Steve referenced, we're doing a strategic assessment again across our 10 highest specialties, particularly in planned care, in Q4, which will really inform our approach to pathway redesign. We will need to invest in clinical leadership in our health board to help us with that. Obviously, we're a very different health board in terms of our pattern of employment of consultants. We're also doing a lot in the urgent and emergency care space. So it's not just planned care. We've seen a big reduction, 40% in use of community hospital beds in NHS England already this year through Elaine's team, and we'll be building on that in terms of further work from Phase 1 of Better Together. We are fortunate that we're actually an integrated commissioner and provider. We can do a lot more in our provider arm to keep patients closer to home so they're not going into England, into actually our Welsh providers for those.
I suppose what I'm trying to get to is about, do you feel you have the levers to actually manage the contract with your partners in England?
So I think we've been an assertive commissioner this year. You'll know we've taken a difficult decision around commissioning to NHS waiting times. We've deployed all our levers in terms of our skilled negotiation tactics and our financial levers, and you'll be aware, particularly around one of our providers, we've deployed that. We're assertive in that space, we're reasonable in that space, but we're not afraid to deploy those contractual levers, and we'll continue to do that.
Thank you.
Could I just invite our medical director, Kate, to add to that? Is that okay?
Yes.
Yes, thank you.
Good afternoon, everybody. Kate Wright, Medical Director. So it was really just, I think, I'd just quite like to draw out some of the clinical inputs into some of the referral management processes, which are growing. So we've got a formal system rapidly evolving, which is great. But some of this has all evolved organically, which is the way we'd like things to happen, and is coming from our primary care colleagues. So the teledermoscopy, for example, has been led by primary care, started in 2024, and is significantly reducing the number of referral or face-to-face referrals into secondary care, and so reducing travel. It really benefits the whole system, both primary care, patients importantly, and secondary care. So that's been a brilliant system that's been led by our primary care colleagues, and I think they're now helping to roll out to train the rest of Wales, which is great.
So this is about how you could do more as a provider rather than external.
Yes. Whilst these are all small things, the reason I think they're so important is with primary care helping lead them, it's building sustainability to primary care at the same time, which is absolutely critical. So we have 4 or 5, as we've outlined. So this dermatology is a brilliant initiative going on with the GPs who are doing early cardiac monitoring for arrhythmias, so whereby you normally have to wait months for a monitor. The GPs will put one on day 1, diagnose an arrhythmia, and it's cost neutral. But what it's doing is reducing significantly the number of people having to go into secondary care, bringing forward the management significantly. And again, that's primary care led, and that's another really nice project. So we tend to start small, learn, see if it's sustainable, because what we don't want to do is build fragile services and then spread. And that's a model which is evolving alongside the kind of more, we do need more clinical leadership. We've invested in an AMD in planned care, which is helping. Some of the changes in pathways needs leadership within the health board to drive it.
Okay.
And that hasn't been a strong point, but is growing. We're investing in that, and I think that's critical for us.
Okay, we're going to come back to the whole shift out of hospital into community, because I think you're in an interesting place there, aren't you? So we could definitely come back to that.
Transit everyone, Alex, Instructor of Finance. So I'd like to ask a couple of questions on the financial position, but briefly, we might just follow up on the agency conversation. Sorry to go backwards. So I think I'm right in saying that the largest area for progress has been largely in registered nursing workforce, yourselves as a board, and in a couple of other areas. Around 20% of your medical workforce pay bills remains locum and agency, I think for reasons we understand, but quite a big outlier in a Welsh context. So I guess briefly, prospectively, where is your attention in terms of some of those persistent areas and how you address those?
So, Kate, please.
So obviously we're looking at the medical locum budget very carefully. So we have a tiny number of secondary care doctors, around 30, the majority of whom are mental health. a couple of community paediatricians and 1 or 2 geriatricians, so we're very tiny teams. I think the challenge, there is fragility in mental health. I think the latest figures I've seen are that nationally the highest number of vacancies are in with mental health, and that's more than double any specialty. So it's already a challenge specialty. So that said, we have gone from a position of using about 50%, which is very high, down from 30% now, still a way to go. Recruitment is challenging, but we are recruiting against the tide. We've recruited 4 overseas doctors who are settling in brilliantly and looking at alternative models. So we're looking at sharing ward doctors between mental health and physical health wards, for example, and that's an issue. So we're trying to think outside the box. It's a period of focus. We've got the recruitment drive going on at the moment, which we hope will reduce the locum spend yet more. So it's challenging. And for me, it's as much about quality and safety as it is about finance. So we do get good locum doctors, but what we know is they don't contribute as much to governance and the general safety and quality. So same with agency staff in general, then I'm really keen that we reduce as much as we can, because we want everybody to be involved in sort of quality improvement, service transformation, and that's how we'll get there.
Yeah, and then on the financial position, to recognise your description of the position of the drivers. So Peter Haley, where Jacqueline and I met with you earlier in November, there's a risk to the delivery of your forecast of around 5 million was our discussion at that point. Obviously, the concern is the end of November. So we try and understand what that position is and how confident you are in the delivery of the forecast and next steps here on that.
So again, this is something that we have looked at very, very closely and continue to look at. I mentioned earlier, we take it very seriously. It is urgent. But I will ask Hayley initially if she would just respond to that question. You may want to bring Pete in as well, Hayley.
So couple of things really. Firstly, the work that we're doing at the moment, as you're aware, you supported us in terms of the independent assessment that's currently being undertaken by Grant Thornton about financial position. And we are due to receive that report next week. So we will be taking on board the findings of that immediately and making sure that we're building any further actions that are identified within our plan. I think the key areas we're still driving out is around those key areas of commissioning healthcare, out of area mental health spend, and also obviously the continuous focus on reducing further our agency. We are planning to ensure that for our month 8 submission that we're able to provide confidence in terms of where we think we will get to in terms of that forecast position. And that's the timescale we've been working to ensure that we come back to you to give you confidence around the additional mitigating actions that we need to take.
Do you want to add anything, Pete?
Yeah, so at the moment, that 5 million, there isn't a line of sight to cover that 5 million pressure. Those actions, as Hayley described, we're working through to be able to call that position. We're still going at it.
Yeah. My last question, please. So, recognised comments at front chair around the organisation's deficit has grown since 2023 on an annual basis, and probably a shared ambition for having a really clear route map. I think at the heart of the Cabinet Secretary's question earlier around needing to close your savings gap in year this year is actually wanting to have a shared view of a really robust route map that gets you to a sustainable position. So I guess what is your timeline around that? And what confidence can we have that when we have that plan, it'll be robust?
So, as I said earlier, the route map has more than one dimension to it: commissioning, productivity, efficiency, and our transformation model. So, but in terms of our transformation model, Better Together, if I could ask Deb, who's the executive lead for that, to the timeline of that. And we had a public board meeting yesterday where we, I'm sorry,
Just to say, I want to come
Okay.
on to Better Together and have a fuller conversation about it in the next agenda item after this. So
Okay.
we can pick that up then if that's okay with you.
Absolutely.
Okay, good. Well, let's move on to the second block of the discussion, which is around improving access for all. We've already touched obviously on some aspects of that in the earlier discussion around commissioning, but Carl, would you and your team like to give a brief overview of
I will invite Simon to introduce comments here, please.
Yeah, thank you. So our integrated quality and performance framework sets out the board's approach to scrutinising and assuring the quality and delivery of our provider and commissioned services. This includes earlier recognition of areas requiring focused intervention through our internal escalation framework. And over the last year, we have used this to drive improvements in our mental health and children's neurodevelopmental services. Due to the hard work of our teams, our provider performance in many areas is strong. We have no patients waiting over 104 weeks or 52 weeks. Therapist access for children meets the 14-week target. Mental health services for under 18s exceed national standards, and we continue to meet the 4-hour waiting time target in our minor injuries units. However, challenges remain. Diagnostics waits are longer than we would like them to be against the 8-week target, although recovery plans are in place. Our adult mental health services report variable performance against the mental health measures due to small teams, with evidence of improvement, particularly with regard to psychological therapies. On commissioned services, as we've already discussed, after careful consideration as part of our 2025-26 annual plan, we agreed in March to commission all planned care services for Powys residents to Welsh waiting time standards, and we continue to monitor the impacts of this change through our integrated quality and performance reporting. There is, however, variable delivery across our commissioned providers of the Welsh waiting time standards, as well as in cancer pathways and emergency department waits for Powys residents. And handover delays persist, with nearly half of transfers for Powys residents exceeding 45 minutes. On quality and safety, incident reporting is stable. Most incidents are low harm and infection control performance is good, with 0 bed days lost and good progress against national reduction targets. Our duty of candour compliance is improving, as evidenced through audit. Some of our services, particularly mental health and in-reach planned care, are fragile due to our widely distributed services and reliance on visiting consultants. This is an important focus through our operational improvement and Better Together programme. Patient experience continues to be a priority for us. We are finalising our People's Experience framework and strengthening feedback mechanisms from our provider and commissioned services, including patient-reported experience measures and digital surveys. We are actively promoting efficiency and demand management and have launched our MSK referral optimisation service, optometry filtering, and the Waiting Well service. These are all reducing pressure and improving patient journeys. Digital transformation and partnership working remain central to our approach as we focus on improvement, delivering our plans and transforming services through our Better Together programme. Thank you.
Thank you, Simon. So we'll come on to some of the performance figures in this discussion. But Carl, I was just to pick up on the themes that we've already started to talk about, really, which is, in a way, the unique position which Powys is in because of your role as a commissioner, because of the challenges which come with some aspects of rurality, and because of what we're trying to achieve in all parts of Wales, which is to have care provided and access to care provided as close to people's home as possible. And I'd be interested in hearing from the board. The CMO is leading a piece of work about community by design rather than hospital by default, which is where we probably are too much at the moment. I'm just interested in hearing from you what that feels like in practice from your point of view, because in other health boards, it's about moving out of one part of the health board's activities into another. That brings its own challenges. Obviously, that isn't largely the experience that you're going to be looking at, and I know that the board will be able to describe where we want to head to, but just keen to hear what that feels like now. You know, what actions you're taking now to bring about that shift, given your unique position, really, to lead the way, arguably, in Wales about how this can look.
Absolutely, and we're very aware of that. And I will ask Elaine, our Executive Director for Community Primary Care, to come in and explain, as you say, what we're doing now. Yeah. But I hope we are implementing as a board our strategic intention and direction about repatriation closer to home, and so on. So Elaine, please.
Thank you for the question. I think, as you've already mentioned, Powys is in a fantastic place to be able to take a lead role in some of the community by design work. And I think there's a sort of grounding foundation principle that we need to get right, particularly with our general medical services, which means that we've got sustainable general medical services. I think there's been significant progress this year around that. But then,
can you talk a little bit about that?
So in terms of sustainability for general medical services, we have had some development with a couple of our practices that had experienced sustainability challenges. So we've supported them with some resource and some support to enable them to stabilise. And we are also working to review how we can work collectively within our collaboratives and within our clusters to wrap around areas where we've got less stability. So we're also looking at our clusters. So we have 3 of those at the moment. We're looking next year that we will move to 2 of those. And there are good conversations around how we increasingly work then at a Powys level.
So do you imagine commissioning more from a cluster on a cluster footprint? What's the sort of, what does that feel like from your point of view?
So I'm absolutely eager to get to the place where we can commission by population through a cluster rather than commissioning through individual providers through service level agreements or service specifications. Yeah. So we are currently in that place where we are commissioning for individual providers. And I'm aware of the work that has been undertaken in Wales and is getting to the end point that will allow us to then commission by collaboratives or at cluster level. That starts to open the door for us to be able to work for populations then, rather than based on the sustainability of individual providers. We've got one federation in Powys already, the Red Kite Federation in the south of the area, and we've started to have conversations with other practices of collaboratives and clusters around how they can come together and work differently to be able to deliver collectively for population.
Can I just ask you, because one of the challenges in other health boards that have, DGHs, for example, is how you move, and they're challenging questions, how you move resource from one part of the system to the other. You've got a slightly different set of challenges and contexts. So how does that translate into delivering the same outcome in Powys on the ground in a primary context or community context?
I think there's always going to be challenges to that in that it's a more straightforward commissioning arrangement if we were to shift activity from our NHS England providers. We have different commissioning arrangements there than we do with our NHS Wales providers. And because our Powys is so large and our population is so spread, we will commission from different providers for the same services. So that causes us some challenges depending on where people live, and we need to build that into some of our collective thinking for our population. I think that we've got some good examples of where we have been able to do that. So you have already heard today around our musculoskeletal and CMAT service, which has already moved around 42% of referrals that would have been orthopaedic referrals into secondary care into our CMAT service, which means we are delivering more locally for our population. We have first contact service providers, particularly around physio, as well as looking at some of the dermatology services, some of the cardiology services that we've already talked about. We're also looking at how we shift services from secondary care into primary care, not just in terms of planned care, but our unscheduled care providers. So looking at our integrated community teams and our reablement and enablement services. So we know that we are reducing the amount of activity that's happening in NHS England community hospitals. So we've seen a 40% reduction in the use of those beds this year.
And that's happened because of what specifically?
So that's happened because we have implemented our community flow systems. So that's focusing the work of our care transfer coordinators and discharge liaison officers. It is also then bringing in that reablement focus so that we are better able to look after people at home, and it's linking in with our local authorities around the adult social care support that they can offer, increasing their assessments. And certainly within the last 2 or 3 months, we've seen the amount of social care assessment delays that we had come down significantly. So we're doing that focus. The other thing that I think is really important is the community resource team and virtual ward specification that we've got in Wales. So similar to the high risk population supplementary service that's been issued as part of winter, we have that similar service available through every single one of our practices throughout the whole of the year. And that gives us an opportunity to more proactively and preventatively work with our high-risk populations. So our ability to grow that and have an impact on unscheduled care is also part of where we're going.
Okay, that's excellent.
There are other things, but I'll hand back to you.
Okay, thank you.
Sorry, Cabinet. So if I could just ask our medical director to add to that some observations around our frailty provision. And if we had time, Paul, who's our executive director for nursing, only been with us a few weeks, so but may want to add something around health hubs and primary care, but only if we have time. But Kate.
So thank you, Elaine. And just to add that we brought in some temporary service changes around co-location of the wards, and one of the reasons for that was high use of agency, which reduced, but also there was good evidence that we knew we had long lengths of stay and deconditioning. So that was all about outcomes, and talking about outcomes. So they have been effective, and the evaluation was that they were effective in helping to reduce length of stay, and importantly on the rehabilitation wards to massively increase the access to dedicated physio and rehabilitation. So that undoubtedly has contributed. So that's part of our transformation journey. I think in terms of an example of how we might move from secondary care into the community, then we are very much about multi-professional working. So, for example, we know the evidence behind complex geriatric assessments, frailty assessments, really strong evidence for better outcomes. Traditionally, that's done by consultants in hospitals. In Powys, we've introduced, it's no longer a pilot, we have got AHPs who are doing the CGAs. Can't do the whole thing, they can do the lion's share of it, and that's enough. We will supplement it, but that's been running for a while now. And that's it's a slow build. We are organically growing the frailty service, really run by AHPs and not doctors at the moment. We probably do need a bit more medical support than we got, to be honest, but working with primary care, that I think is a really strong model.
Great.
And so that's an example of how we are moving and have moved.
Interesting. Okay. Before Paul comes in, I'm going to ask Sue Trecker, our Chief Nursing Officer, that has a question. You may be the person. What did I owe you?
You may be, but let me just think. As a unique, you have a unique position in Wales as a provider and one of the commission services across the border. I'm wondering what oversight does the board have on patient safety, experience and outcomes for patients that are commissioned for services externally? How do you monitor that quality of care? And what is the board doing to strengthen its oversight, or where you find any gaps in care, please? So it might be for Paul. However, Paul is very new in, so I'm happy for you, Paul, to take it. But again, Carl, over to you.
Yeah, thank you. I will bring Paul in. With Simon, who chairs our Patient Experience Quality and Safety Committee, might also want to add a word. But just from me as chair of the board, Sue, again, I am confident that the reports that come to our so-called PECS committee do what you're asking for. They do provide us with that rich source of data and information, and allows us as a board to scrutinise quality and safety effectively. But I will turn to Paul and Simon. If you have anything, please come in. But Paul.
Yeah, and I premise this with being very new to the organisation and new to Wales as well, and the Welsh health system. I think it's a lot easier for us, as Carl has pointed out, to be able to demonstrate a good, robust governance and assurance around quality and patient safety on the services we provide. The challenge around ensuring that we're getting the same level of assurance from services we commission can vary a little bit from provider to provider, and particularly from the Welsh side of the border and the English side of the border. However, we are very robust in seeking that assurance and that data and concerns that may come through our various reporting mechanisms, through our complaint system. We send SMS messages from a patient experience perspective to all our patients that receive care, commissioned care, either in England or in Wales, to get feedback from them in terms of their experience of the care that they've received and the services that they've accessed. And equally, we approach our providers to seek the data and the assurances through their own boards and through their own data quality systems to give us that assurance as well. And we have robust face-to-face conversations or clinician-to-clinician conversations or director-to-director conversations about the care that's been received that we can then compile into our governance structure through to our PECs and up to board. And I'll let Simon talk to the formal governance process that we have.
So as chair of the Patient Experience, Quality and Safety Committee, I absolutely confirm we have at every meeting an integrated quality report that picks up on all of the data we are able to gather. Certainly, I think an area for focus and improvement is how we triangulate that within the commission services, and the development of the strategic commissioning framework is in part helping us to move that dial forward for us. So I think Paul's covered. We absolutely see the data we can get. And I think we know that we can improve further on obtaining more of that data from our commission partners.
Thank you. And I think, sorry to interrupt, but the data you can get is kind of where I'm getting at.
Yeah.
Because what you don't see is what you haven't got. You haven't got that. So relying on complaints is a retrospective approach. Of course, you can take action after that, but it's not great for the patient who's experienced that care. So I guess the strategic approach to your strategic commissioning would be really interested to see. I'd be interested to see what your quality and safety oversight mechanisms are going to be and how you're going to strengthen that through a contracting and monitoring perspective would be really useful.
And perhaps therefore, if it's okay, if Nicola might want to come in, who of course oversees our contract management processes with our contracted providers. So
yeah, I think it is an area of development for us too. We strengthened our integrated quality and performance framework, so it's really clear how that flow of information comes from our meetings with our contractual meetings with our providers, which are obviously based on the LTAs where we specify what data we would require, and that openness and transparency around those parameters. I think we are on a journey to get that, or it is variable. We've got a very complex commissioning environment with 14 providers. You know, we are unique in that, you know, an ICB in England would have 3, but it is absolutely our ambition to improve that and make it less variable. We are considering how, again, we use our contractual levers in that, so how we incentivise that data coming through in the way that we want it, how we potentially put in consequences if it doesn't, particularly around the quality side is really important. And then our reporting then, we've got a commission oversight and assurance group with quality colleagues, multidisciplinary team on it, where we use that data that are getting, but also our intelligence and insight from visits. Like, for example, the chair and I went on a visit to Bronglice because our patients are over there this week. But our staff are out and about in those providers as well. It's really important we use that intelligence and insight as well as the data. And then that features in all our reporting through our PECs committee, our finance and performance committee up to the board.
Carl, so it seems a pretty key area to be on a journey towards getting a stronger position. What would you say is the reason why this, you know, quality and the patient experience is a pretty fundamental thing, isn't it? And necessarily you've got an arm's length relationship with the providers in delivering that. So would you say you're comfortable where you are with that as part of your levers? They seem...
I would say not quite yet. I think it's an area that particularly after COVID, because obviously all the contractual elements and all of that was stood down during COVID, that we've reflected and that we need to strengthen, and that's I think that's why we're reflecting on that cabinet secretary.
Could I invite Hayley to comment on that?
No, thank you.
There is always room for improvement. It's that continuous improvement journey. However, we have commissioned particular deep dives on particular issues. So, for example, we've had experience of dealing with maternity issues for a number of years across a number of our providers. And we link very closely, for example, because the Ockenden review with Shrewsbury and Telford and Egestra, also with Clwmtaf in terms of the Instog and the work that was undertaken there. So although we have got to continue to develop and mature in this space, I do think that we can take assurance from the information that we're pulling together. There's always room for improvement, but I think we do track a number of quality outcome indicators for our population, and we also have that multidisciplinary contact. So, for example, our head of midwifery meets regularly with all of our providers, as an example, on top of the contract quality performance review meeting that we hold, which is generically across all of the matters that we need to cover, for example, finance, access, activity, quality, governance matters. But there's always more that we could be doing.
Okay, Jeremy.
Yeah, Jeremy Griffith, Director of Operations for NHS Wales. Kate's picked up one of my questions, so that's good on the urgent emergency care aspect. I guess following on from Jacqueline and Howell's points on board ambition, I want to ask a question around planned care and then ASD autism assessments as well. So on the planned care element, what is the board's strategic commissioning ambition and how will you measure it on planned care based on the following facts? So there's your Welsh providers have been tasked through enabling actions and through significant funding to make big improvements in terms of the waiting list position, and you're seeing that now through your data pack in a number of areas, particularly for the outpatients. How will that change your ambition now, and how will you measure it going forwards? That be knowing that, particularly on our assessment at the moment, that a number of the outpatient specialties you're commissioning will be in a sustainable position with Welsh providers. So how are you tracking that? How are you getting information from them? And then what will that change in terms of your approach?
I think Nicola is probably the person to respond again, please.
Yeah, we are really pleased to see that improvement in our Welsh providers. Obviously, it is an area that we monitor with them through our contract review meetings very closely. We do need to acknowledge that to some extent that backlog removal has historically been an area of pressure on our financial position, and we have worked with all our providers to make sure that we're not paying through our contracts for backlog removal where that's funded directly by Welsh Government. So that's really important for us. It does mean that some of our levers in terms of sometimes incentivising that increase in capacity and activity aren't as clear-cut as maybe we would prefer them to be. I think in terms of ambition, our ambition is, as a board is to continue to commission to Welsh waiting times. Obviously, in terms of assessing that, in terms of our plan going forwards, we don't have the NHS performance framework for next year yet, but we are completely ready to assess that with all our providers in terms of what activity do we need to buy from them to meet those Welsh waiting times. And that's quite a different approach in NHS Wales that it's been historically, but we flagged that in our commission intentions. So we, instead of rolling over baselines, it would be quite targeted on what do we need to buy from you to meet those Welsh waiting times targets. And that includes continuing with that in NHS England as well. So that is the ambition that the board has, to support all our providers to meet those targets when obviously we see those hopefully early next month.
So I'm sorry, just supplementary on that. You mentioned a few examples we've heard on dermatology, MSK, those elements of it. What other specialities do you think there's opportunity in your planning round now in order to target, where it's currently with, it's currently with either an English provider or a Welsh provider, and actually you may be able to get better value commissioning from it in terms of the Welsh position, because where Welsh providers are making improvements.
Yeah. So ophthalmology will remain, as well as the things that we've already talked about, ophthalmology will remain an area of interest for us. It always comes out really high with orthopaedics in terms of our spend. We have theatres in our community hospitals that are set up to do day cases. We do have a basket of Powys suitable day cases, if you like, because obviously we have to take careful consideration of the anaesthetic criteria in those community hospitals, that we think there's a lot more to go at in the day case space. We think the external consultancy report will really support us in that. A lot more to go at in new outpatients, really incentivising different ways of working, and we're thinking through in our contract design how we really incentivise the parameters, the metrics, and improving performance together around follow-ups. My colleague next to me has also pointed out there's a lot more we could do in general surgery.
Okay. Another question then on the child and adolescents autistic spectrum disorder assessment. So in your evidence pack, you've set out where that is an internal escalation for you. The national learning from other organisations on some of the transformative approach. It'd be good to know where the board is on that transformation at the moment, so we can see that reduced waiting times for these children and adolescents. And actually, from a measured perspective, where do you think you'll be in the next 12 months? What's the ambition around that?
Thank you. You're right.
So-
I take
Yeah, absolutely. I'd like to invite Hayley to comment as well, if I'm Cabinet Secretary. And but do you want to come in now, Hayley? Or
I'm happy to. Just back to your point around our ambition around planned care, a couple of things. In terms of utilisation of our operating theatres in Powys, there's opportunity there for us. And in particular around what I describe as high volume but low complex work. Sure. So that is a really key piece in our strategic assessment around the opportunity for shifting back and repatriating activity into Powys.
How quickly do you think that can come on stream? What's your thinking?
We're trying to complete it. We're going to get a team in to support us during the last quarter of this financial year, so in the next few weeks. And hoping then to build that, not hoping, we will be building that into our plan, integrated plan for submission at the end of March. So there's that element. I think the other issue that I wanted to bring is in terms of efficiency and productivity measurement. I think the MAG report was really helpful. I think it's about how can we actually look in the commissioning space of integrating efficiency and productivity requirements as part of our commissioning relationship provider to provider, which is different to the national framework. So that's about how we further strengthen our commissioning arrangements.
Okay, great.
And just a comment. I mean, Nick mentioned earlier, Cabinet Secretary, our approach to commissioning is changing, very much so. And of course, with change comes sensitivity and so on, both with our English providers and with our Welsh providers. As a board, we're very aware of that, and we want to manage that change very carefully and in a spirit of partnership.
Great. Okay.
The autism assessment.
Yeah, I'll come in on that. So I'm the executive lead for the escalation process. So children and young people's neurodevelopmental services have been in escalation under our IQPR for quite a while. I should note that's neurodevelopmental services around social autism and ADHD together. And the service, we've been on a transformation journey as well as a performance improvement journey. The team are absolutely brilliant. We've appointed a multidisciplinary team there, and I've had the pleasure of meeting them, and they're fantastic. So we're meeting all the 8 national standards for that neurodevelopmental service. We've transformed the way the service runs, both on meeting the best evidence and the way assessments are undertaken, the triage of the waiting list, so forth, and signposting children and families to other services if that service isn't the best place for them to be. The board and we continue our transformation journey to put that on a sustainable footing. There's been a huge amount of change, which has been very clinically led by that team. On that basis, we met the 104 weeks waiting times in that service at the end of March, which we do appreciate for children and their families. There's still a significant amount of time to wait. And as a board, in the agreement of our annual plan for this year, agreed we would maintain that 104 weeks, noting, Cabinet Secretary, that your expectation is to eradicate 3-year waits this year, so we're ahead of that. We are yet to plan that forward, I would say, in terms of our performance.
Can I just ask about
and our annual plan for next year? But we are obviously starting from a very solid footing in terms of the model that we've got in place.
Okay, thanks, Jeremy.
the transformation other organisations have seen that working with the local authority, particularly with education? So is that part of the work? Because you did mention that element there.
I'll bring Kate in. So we do work really closely with education,
Okay.
And making sure that the house service is doing what the house service really needs to do, and
Seen the 3 2-year waits now, and they're actually meeting national targets. So what does that look like?
I'll bring Kate.
Yeah, so we've done exactly that, because it was quite a medical model, I think. So it has transformed. We've got the education, local authority, and I think what is giving me confidence is that the team has absolutely embraced it, but we've seen a significant change in position where we had an extremely high acceptance rate into the service, now down to 50%, because children are being appropriately, after MTT assessment, or after triage, are being redirected to the wider system. So that gives me confidence that we are likely to sustain and then improve this.
Okay, good. I've got one more question, if I may, on mental health, then we'll try and move on to the next block, I think.
Okay.
That's all right, thank you. So I want to ask a question. I firstly want to acknowledge that there may be some sensitivity around this question for those in the room and even for our public observing. But I know the mental health service has previously been subject to internal escalation, and performance has been variable. And then over the last 12 months, Powys has seen a growth of the number of people that have died by suicide. And I note in your evidence pack, thank you for sending that in, that you're still undertaking learning. So there is an urgency for the people of Powys that require you to put in place the actions on the learning to make sure that this doesn't happen again. I'm just wondering whether the effectiveness of the model of care you're delivering and then the learning that is actually taking place, because I am slightly, as you would be as a board, I'm sure that this must continue to concern you for the people of Powys.
But thank you. And again, just from me, and Simon can come in if he wants. But again, just an assurance from me that through our PECS committee, there is absolutely sightedness and scrutiny on those matters. So the information we receive is proportionate, appropriate, and so on for a committee of that type. But certainly, I want to give a kind of governance assurance that we are cited on it. But I will ask Elaine to come in on the detail. Thank you.
Yeah, thank you for the question, Sue. And I think you're right to call out that this can be a very sensitive and challenging issue. I think it's also really important to recognise this is a wider system, wider partnership issue as well. So although we are focusing on this from our mental health teams at the moment, and we are doing that in a partnership, a multi-professional space. So last year and this year, we've seen a higher number of people who have died by suicide. There's nothing to suggest as yet that that's a significant shift or change in proportion of people, but we are undertaking those individual reviews.
Elaine, I don't want to go into the detail. No, that's okay. But just the model of care. So is your model effective is what I'm trying to understand, please. I don't necessarily. Yes. Cases, thank you.
Yeah, no, and I wouldn't want to go into the cases either. I think that it's really important to note that the multidisciplinary reviews have identified that there is and continues to be some work that we need to do with our local authority, with our police and with our GP partners to make sure our model works across that whole system. We have a really fantastic postvention service that is supporting our staff and our population as well. We recognise the number of people who are impacted following a suicide. So at this point in time, our learning suggests that our model is working and working effectively, and that postvention is very positive. But we are undertaking that review consistently and continuously as well.
Okay. Thank you.
With your permission, if I could just ask our medical director as well to comment.
Well, I'm very keen to move on, but
Okay.
if there's to the next, to make sure we cover the ground that we need to, but if there's a brief contribution, give you want to make.
Just very briefly, so just to emphasise that it's a terrible situation. It has been looked at very, very carefully, and with colleagues from NHS P&I, which has been really welcome. I think it's important to say, whilst there is always learning, we haven't identified significant themes and we haven't identified significant failures of care. So I think it's really important that, there's always learning, but we haven't identified any patterns.
Thank you for that. Okay, I'm just conscious that there's so much for us to discuss on each of these topics. We could spend an hour on it, really, but as I'm sure you will all appreciate that. So the third substantive item on the agenda then is how the Health Board is getting services ready for the future in line with the 10-year plan, Healthier Wales. So who would like to speak?
We're back with Simon.
Thank you, Cabinet Secretary. As a Health Board, we are proud to be playing our part to deliver the Women's Health Plan for Wales. To achieve this, we're developing an innovative Pathfinder Women's Health Hub suitable for our highly rural area through a mixed method model combining community locations and virtual access. This hub will focus on menstrual health, contraception and abortion care, and menopause support. It's a bold step towards prevention, early intervention and continuity of care. We also provide midwifery-led care for around 1,000 births each year in our community hospitals. We have no consultant-led obstetric unit, so collaboration is key to promoting quality and maintaining safety. And we've invested in 2 senior leadership posts in this area in 2025-26. We've fully participated in the All Wales Maternity and Neonatal Assurance Assessment and the MAT Neo Cymru programme, as well as other national improvement and assurance mechanisms. We directly provide the majority of mental health services for the Powys population across a range of subspeciality areas. Following the internal escalation process referred to in the previous section, our expert mental health teams have made significant progress in reducing waiting times. They have redesigned pathways, introduced new roles and improved access through initiatives like 111 Press 2. We're tackling challenges such as the increased use of external placements, working closely with partners to provide better support and prevention closer to home. Prevention remains a cornerstone of our strategy, A Healthy Caring Powys, and the recently board-approved Population Health Strategic Framework is giving focus to preventing the preventable. Reflecting population health needs, we're driving vaccination uptake, tackling smoking and vaping, and promoting healthy weight in children in line with our ambition that by 2035, everyone in Powys should live healthier for longer. As a rural healthcare organisation, our primary care and community service models underpin everything we do in Powys. We're embracing and developing integrated models of care through programmes like Better Together and the North Powys Wellbeing Programme. Our goal is to keep people well at home, reduce unnecessary hospital admissions and provide care closer to home. This includes strengthening dental and optometry services and supporting the education and training of our workforce through the Primary and Community Care Academy. Finally, digital transformation is enabling us to deliver care that is connected, efficient and patient-centred. From electronic prescribing to shared care records and AI-driven insights, we are driving forward a number of national and local digital innovations. Thank you.
Thank you, Simon. Well, so you have the Better Together programme service transformation, and then you have a number of temporary service changes affecting Brecon, Llandrindod, Llanidloes, Ronllys, War Memorial Hospital, Montgomery, County Infirmary. So quite a number of temporary service changes. If I was a clinician in Health Board, how would I describe my involvement in the strategy Better Together and also those service changes?
Yeah, so I'll ask Paul to come back on that in the detail. But again, just from my point of view, we have kept a very careful eye on the engagement, the comms and the participation arrangements around this journey that we're embarking on. And we receive assurance reports, both as a board and through our committees, on the effectiveness of that. But I will bring Paul in on the detail.
Thank you, Carol. Again, being fairly new, I might refer to Kate as well for some of the more detail if needed. But our clinical engagement, and I would think our clinicians would say and recognise, has been very strong. We have clinicians in place for all work streams of phase 1 of Better Together. There's clinical leadership in all of the programmes for Better Together through phase 1, and we also have a clinical reference group in place as well. We also seek advice and support from clinicians beyond our own border in terms of specialities and bring them into the conversation on a regular basis, and they've been supporting us on that journey. We've run clinical and professional workshops to test out some of the findings coming out of the consultations through phase 1 of Better Together. And we've also sought external clinical expertise around community and integrated care. And equally, in some of our more challenged areas around planned care, we've sought external expertise as well, and equally with mental health. So I think overall, our engagement has been strong. And I think our clinicians would reflect that.
So would you describe it as clinical engagement or clinical leadership?
I think it's a bit of both, because the workshops that we've run and the consultations that we've gone out to into our health board, out into our community hospitals, and both the public and the clinical forums that we've run, I would class as our clinical engagement in sharing our ideas and seeking ideas from the floor, and equally to drive some of that, we've had good effective clinical leadership.
Again, Kate might want to comment. Thank you.
So I think you've really nicely summed up, Paul, but just to say that it is really important to us. I think we've had really excellent and growing engagement and really constructive conversation. It is both leadership and engagement, and I think importantly we've really tried to bring forward the voices of primary care and appoint them and give them protected time.
That's a challenge though, isn't it?
Well, no, actually, it doesn't need a huge amount of time.
Okay.
So we have had to go 2 or 3 times to find people, but we have found really good GPs who are turning up to every event, and we're asking a lot of them for time, and it's worth the investment. It's essential.
And it's probably just worth adding very briefly, Cabinet Secretary, that I as Chair and some IM colleagues as well have attended and been part of the engagement with clinicians through workshops and various visits and meetings and so on. So it's not just been through the executives.
Okay, that's helpful, Carl. Thank you. Chief Medical Officer.
Thank you very much. Isabel Oliver, Chief Medical Officer. I just wanted to expand a little bit on that because I know obviously we're talking about clinical leadership and that's multidisciplinary, but you are in a unique position where your staff profile is a little bit, it was significantly different. I was just wondering, how are you managing to bring in medical expertise and medical leadership into that, and whether that relies a lot on bringing that expertise from outside your borders, and if so, how do you make sure that you are getting a coherent picture and you're not getting multiple different views? And if I could expand on that, so I wanted to congratulate you also on some of the public health achievements, which are great to see. However, you didn't mention public health input or expertise in that redesign. And when you were describing your community by default approach, I was just wondering how you are embedding prevention into that, and how is that shaping, how is the public health expertise also shaping your thinking? Thank you.
Thank you. I will bring Kate in. That's a really interesting point. I think from my point of view, again, just from an independent member chair point of view, I've attended almost all of our, what we call our deliberative events and so on, and public health is certainly centre stage, and some of our public health colleagues have actually been the source of really crucial and key information in those events. So, but I will hand over to Kate. Thank you.
So yeah, thank you, Isabel, and thanks for the question. So I'm acutely aware that a challenge for us is that we've got small teams, quite disparate, and peer review, peer challenge, peer support can be tricky. So we've got really good expertise in county. We've got GPs who I think do more than in rural areas by they have to. And so a lot of them have, for example, frailty expertise. So we've harnessed that wherever we can, because that's important. They know the patients, they know the patients really, really well, and they are their advocates, as are the rest of our community teams. But that said, it's really important we look beyond our borders. And so we have had some amazing help from 2 or 3 external experts. So Professor Henry from Scotland has been absolutely brilliant in coming, being a critical friend, looking at our model, pointing out opportunities, but really helping to lead us. I'm a generalist, so I can have a good go at it, but there's just something about having a really credible voice in the room as well, which we have lacked. And we've had help from neighbouring health boards as well, which has been fantastic. And one of the things for me, which is the most affirming, is that they are genuinely engaged in what we're doing, and are actively supporting us and actively helping us. And I think that is really, really positive. In terms of public health, absolutely, they have been really helpful and integral into helping us with some of the modelling and design. So they absolutely are in the room and really drive us. We were all driven, I think, we all want to be in the prevention zone, but they absolutely drive us there, which is really, really important. And so I think the whole community model it's called Better Together. It is about bringing our teams together, but it really is about making sure we are preventing what is preventable and trying to do as much as, I think the ethos is that we want to provide as much care in the community as we can safely and sustainably do so. And that is the ethos. And that is, I think, why everybody is so engaged, because that's what everybody wants.
And sorry, I think Hayley wants to come in. Just a quick point from me. Kate mentioned Professor Anne Hendry, and I think one of the most important things I've learned from her and from that expert clinical leadership perspective is that her emphasis on, if you're on a transformation journey, it is almost never linear. And the real need to be responsive, agile and flexible. We'll come on to timeline, I'm sure, Cabinet Secretary, and I think that's one area that we've certainly learned that. But Hayley.
Yeah, we have a 10-year strategy which we set in 2017, which comes to an end in 2027. And one of the cornerstones of that has been focus on wellbeing. We as board in September, we couldn't bring the whole board, but Nes Bowley, our Director of Public Health, and the team have really helped us in developing a new strategic framework, which we approved in the board in September. It's called Preventing the Preventable, and we're trying to integrate all of that thinking in the approach that we've got. But I also wanted to mention partnerships. So the Regional Partnership Board and some of the work that we do in terms of the commissioning cycle, that needs assessment work is absolutely critical to us. And that is continuously updated. We've got a warehouse that we use in partnership to continue to look at that work, and it's due to be updated again sort of formally next year. And that drives a number of the proposals that we've put forward in terms of Better Together programme.
So just on, if I'm a resident of Powys, when will I start to feel the effect of Better Together once it's gone through the board?
If you are a resident, well, let me bring in Deb. Please come in, Deb.
So you might not feel the impact of some of the output. So when we got through stage one, clearly there are elements of it which will be controversial to our public, which will require consultation. But there are lots of
individual elements that you mean?
Yes. So I mentioned beds earlier on, but there will be a range. But there will be improvements that we can implement as part of our integrated plan for next year that don't require public consultation. So I would hope our public will feel the positive impact of that.
What sort of things might those be in general terms?
Strengthening community care. We talked about the work of Professor Anne Hendry. She looked at a day of care, and she's given us some feedback on that. She's given us some feedback about flow and urgent care and how we can do more with our commission partners. Okay. So those things are about how we use our resources, disciplines, eligibility, and all of that. In terms of then the other elements which will require the public consultation, we've done phase one. Just to go back a step, we didn't have an improvement and transformation team until October last year. So this year has been very much about setting the infrastructure, the governance, the priorities and the plan. By the end of March, we will have the first phase of that completed, and will already have mobilised the extra support that we're bringing in to help us with planned care. And I think Hayley and Nick described that. So at the end of Q4 next year, we will have that. We need to then consider the timeline and the conscientious consideration for phase one. So we're saying that we will be going out to consult on phase one September next year. Then we build in conscientious consideration, which takes us to a board decision the following year.
Okay.
And so on and so forth. So we're building that plan, and just to conclude, if I may, the timeline for the rest of Better Together is coming to board in January.
Okay, that's helpful. Can we move on to the fourth of the four areas then, which is in relation to strengthening how we run the NHS, and in this context, how you are strengthening the running of the health board.
And Steve is going to offer some comments initially, please.
Thank you. I think we've probably touched on some of these areas already, so I'll try and just focus on the highlights really. I mean, in his opening statement, Carl referenced, how we operate as a board, and we continue to ensure a stable footing, stronger governance, and consistent leadership behaviours. And effective partnership has enabled us to plan and deliver improvements with confidence. We have a stable board, both executive and non-executive, and we're very focused on ensuring a high-performing culture, behaviour and decisions are taken in a timely and effective way. We have already touched on workforce. Our workforce strategy is delivering results, enhanced vacancy controls, and real-time analytics have improved decision-making, and as we've outlined already, reduced agency reliance. So non-clinical agency use is now down to 0, and nursing agency shifts have fallen by 66%. And we've achieved a 35% reduction in nursing vacancies since 2023 and increased bank utilisation by 30%. It's also pleasing to note that our international recruitment has strengthened key services with 100% OSCE pass rates for our international educated nurses with 0 turnover. Leadership development is thriving. Over 200 staff have completed the structured programmes, and our clinical leadership immersive programme is gaining national recognition. Our staff engagement index stands at 75%, and 80% of staff feel valued by their line manager. And as we've been just touching on, through our Better Together programme, staff voices are really helping to shape our transformation. Wellbeing remains central to us. Over 700 staff have accessed our employee assistance programme, and more than 1,000 have attended wellbeing roadshows. In terms of recruitment and education, we've cut time to hire by 20%. In 2025, we've delivered over 220 clinical placements, and our successful Grow Our Own nursing programme continues, enabling local people to train and work in Powys. And also the HCEES Schools programme has engaged 5,500 learners, and partnerships with the university are building future medical and digital capabilities. So we're also, as an organisation, strengthening our investment in core skills across the staff range and competencies. And these achievements reflect our growing confidence and capability. So we're not complacent, but our focus remains on quality, leadership, workforce resilience, compassionate practice, and robust governance. Yeah.
Thanks, Steve. I'm just interested in the point you're making about this is my main question, the point you're making about the clinical leadership programme, and this isn't a question specific to Powys by any means. I think it's a general application, which is how you measure if it's working. So staff will tell you, presumably, that it's beneficial, and presumably they would, because it will be to them, but I'm thinking from an organisation point of view, are you at a place yet where you can see the effects of it in the organisation, or would you not expect to be able to measure that?
So thank you. So we are evaluating it. We've been through an evaluation framework when talking to Health Education Improvement Wales, who want to roll that out on a more broad basis. I think in many respects it's qualitative. The confidence of an individual having practiced in the safety of a space away from their team to actually stand up, talk about improvement, talk about the challenges with leadership, where people are maybe feeling imposter syndrome. So people are being more confident, and we've got the checking going back to those individuals. How does it feel now, 6 weeks on? So what are you doing instead?
So that's a completely get, and I'm not at all surprised to hear that. I mean, that's just it's obviously working at that level, and this I'm just interested in your take on it. Really, it's not a particular concern I've got, but one of the things in programmes of this sort generally seems to me is there a means by which you can capture more effective productivity in the team, for example, or better practice in whatever sense? Do you have a sense of that being a possibility?
There's probably more to do, and certainly is a possibility. And I think just going back to the question around clinical engagement, clinical leadership, if we look at the individuals that are in the work streams, that are now leading work streams were led, the temporary service changes, they might have been individuals who would not have stepped forward before. So I think if you could leave that with us, Cabinet Secretary, we'll think about how we might capture it.
To Powys, I'm not making that point.
No,
it's just interesting in your take as an organisation, whether there's more we could probably all be doing in that space. So my main question, Carl, is this. So you've got your staff survey results are showing good levels of engagement, which is obviously very positive, but also highlighting quite significant concerns in some spaces around what's described as burnout and stress. So I'm interested in hearing from the board what staff are telling you about how to improve morale and what you're specifically doing about that.
Yeah, so again, I think it's important just for me to say that both in board development sessions and in more formal routes, we are aware of those things. We receive that information as a board, and it is certainly something that is a subject of discussion, consideration, and decision making for us as a board. But I will turn to Deb as well for an operational response. Thank you.
Thank you. In terms of the data, you're right. You're right. It's worrying. I think we've got probably today 30% of the workforce off with stress, anxiety.
What percentage?
I think it's about 30%. 30% of our absences. So
A longer meeting.
I can be here till evening. Yeah, so 30% of absences, stress, anxiety. It's still high. We'd already seen a trend within our data before we had the last year's staff survey results. So we implemented a deep dive, and as a result of that, put in place a number of actions, one of which was a targeted case-by-case conversation with the individual if they are kind of open to the conversation, or via the line manager. What can we do to encourage that individual, support that individual back into work? What were the factors, if they work related, that led to the absence? We also piloted an initiative called Mindful Acceptance and Compassionate Support. So we piloted it with 50 individuals who are either already off sick or were talking about experiencing burnout. They did a subjective unit of distress measure at the beginning of it. Then they had individual sessions or class sessions, or were signposted to resources, and then we did a measure after significant reduction. So much so that we've implemented that. We've rolled the pilot out, and it's now in place for 2 years. So 173 people have either had individual or group support to help them express, describe, and have some supporting tools to help them with any of that. I think back to the workplace, one of the highest of the indicators were things like, I haven't got enough energy outside of work to do things with the family. And we've been re-promoting the 15-minute wellbeing break, which is something that the health board put in place a number of years ago. I think it got a bit lost in COVID, and we've reaffirmed that, encouraging people to take that space. In addition to that, we've got a 24/7 access for individuals to counselling services, so confidential to individuals. So there are a range of support tools, but I think part of the question is making sure that the environment is not creating that, and that's where we're doing some of the bespoke work. And I'll give you one example without naming the service. We had a request from some team members. We had a higher level of sickness, and we had medics saying we need some help. So we've got an organisation development person in there, as well as the mindful acceptance and compassionate practitioners supporting that individuals, and we've seen a reduction in sickness. I'm looking at Elaine, and an improvement in kind of team dynamics. And
yeah, we've seen a 50% reduction in sickness in that particular team.
Okay, I was keen to hear that. I mean, because there's two models. The one is how you help an individual to cope, as it were. The other is reading the signal about what that tells you about the environment in which they're working. So I'm pleased to hear the second part as well.
Hayley would just like to add a comment if
yes, of course. Then I have this soon.
Yeah, it's really important from my perspective that the work of the board in setting the culture of the organisation is really important. And we talk about compassionate leadership, so I know the compassionate leadership awareness work that we've done across the organisation. Over 500 staff have attended that, and we really do attend to how we do our business. One of the things we talk about a lot is how do we appreciate, focus on the things that aren't going well, but also continuously build morale of the teams, because people are doing well. They're very proud of their work. So the staff stories and the awareness of what is going well, we've got to balance that in the board meetings, not just focus on the areas where we're seeking further scrutiny and assurance. And I think that, you know, our staff survey results, we always want a better return rate, and obviously it closes next week on the 1st of December. But I think it's really important also in how we're able to go back to the staff about what we're doing, about the results that come from that work. So particularly our staff side, scheduling partners work closely with us, and we've got a really lovely team, Chat to Change, and also the Wellbeing Roadshows that we do, which I attended only last week in Llanidloes, and I know we try also. Visible leadership is really important.
Push back
for
the
the board.
points that Carl was making earlier, actually. So that's helpful.
Especially in a rural county.
Diolch, Amy. Isabel.
Thank you. I was thinking about preventing, burnout and these kinds of, improving staff well-being generally. And two components as part of that. One is how is that informing, how's the staff well-being informing your work around service transformation and around your clinical services plan? And second, there was also feedback in your staff survey around recognition and career development. And I was wondering particularly around career development, to what degree, because of the particular circumstances of the health board in terms of the dispersed nature of services and the range of services you provide, whether you have thought about, working with neighbouring health boards or others to think about how you provide career development opportunities. Thank you.
I think Deb as well, coming in on this, please.
Yeah, thank you. So one of the kind of backdrops to the case for change and better together would have been workforce fragility, which will consider the fact that we've got high levels of staff describing burnout and stress as being one of the reasons. So, it's not just about the estates or about agency, it is about looking at the staff that we've got and making sure that the environment, the demands on them are appropriate and reasonable, and also giving them the protection of a more resilient workforce around them. And the other element of that then is the kind of recognition of career development. And when I first arrived in the health board, which was only a few years ago, and went out and spoke to staff and said, what is missing? What is getting in the way? It is, I'm never going to move from here. I'm in an 8-bedded ward. I don't have any career progression that is obvious to me. And I think, we've seen that particularly with the temporary service changes for the minor injury units, people seeing that there is an opportunity to grow their skills, develop the competence, think of, banded roles in the health board or even elsewhere. And I think the last bit of your question was around the extent to which we look for career opportunities and development with partners.
Was it more about thinking if what you're able to offer is constrained, whether you are working with others to consider how you can provide development opportunities beyond ours?
Yeah, could I just invite Kate to just comment on that from a kind of medical staff perspective?
I think it's a really important question, Isabel. Just sort of quickly indulging myself and going back to the discussion on burnout and just general well-being. I think there's, as well as all the initiatives, there's just something about people feel better when they're in control and they understand what's going on and they're having feedback. So I think that actually the transformation and the engagement that we've got and this constructive conversation, I really hope will, because we're quite good at recruiting, it's retention we all struggle with. And I think that when people feel in control, they feel listened to, and we're working really hard on that. I think there's always more to do, but so I think that's really, really important. And there's just something about how we're feeding back. We do have challenges. We know that by 2030, 700 of our staff will reach 61 years. So that's coming fast at us, and we're very aware of that. We've all got, I think, through the disciplines, we are growing our own. And and developing our own, and that is working well. There is something about, I'm very conscious, I've already mentioned the fact that we've got tiny teams in a fairly closed environment, and I think peer support, peer review and challenge are incredibly important. So we've had a traditional model of in-reaching through SLAs, but increasingly I think we're looking to reach out to other health boards to look at joint appointments. I don't think Powys is necessary. For some specialties, then standalone appointments work very well, but there's something really important about reaching across. And actually it's happening organically. People are coming on a sessional basis to work with us. That brings in external expertise. It adds another element to jobs. And I think we've talked about it in nursing and the therapies as well about rotation, but actually people want portfolio careers now. And so that conversation is growing, and I think that's a really strong model for us. And also developing GPs with special interests. That is absolutely our strength. We've got GPs, we've appointed a couple, we've got our own GPs who we really need to develop. So I think it's multifaceted. It's incredibly important, especially given the fact that we're quite isolated. We need to look beyond our borders, and we do.
Thank you very much. I want to acknowledge firstly the good work that you've done on the Grow Our Own approach. I think it's really, really great. And your ACs, I really love that. And the primary care school, primary school pilot, I think is fabulous. Can't wait to see what that brings. So well done. I want you to say that first. But on the other point, we went back to the burnout and stress, if that's okay, please. I wondered whether the board had made any consideration of a correlation between your 30% in absences that you're seeing now with the very fast reduction you saw in variable pay, and whether that had left any gap in terms of your recruitment and retention areas, and whether that is driving it in particular professional groups. I think it's quite a layered question. Apologies for that.
Yeah, you can say that.
I'm just giving it a moment.
Yeah.
But could you just sure. So have you made any consideration around whether there's been correlation with you reducing your variable pay quite quickly? Actually, you've done a really great job with registered nurses, particularly. Let's take that. And then suddenly you've seen this 30% of stress burnout in your absences. So it feels like it's almost coming at the same point. So is there at some point where they cross over and you think this has happened? Your stress and burnout is happening because you suddenly reduce your numbers of people available on the wards.
Thank you, Sue. Elaine would like to come in. Thank you.
Yeah, it's a really interesting question. I think what we've not seen necessarily is less people on the wards. What we've seen is more sustainable staff on the wards, which I think has been a really positive indicator and has really supported some of the development of team morale. So I don't think it's had a negative impact. We've not seen any incidents or growth in any of our adverse incidents. So at this point in time, we haven't seen that connection there. We've seen probably it in the opposite direction.
Okay, thank you. Carl, we've reached the end of the 4 areas that we were hoping to discuss together. So there's an opportunity, if there's an area or any issue that you feel you want to put on our radar or that you haven't been able to address so far, there's a few minutes for you to do that. Don't feel that you have to, but there's not.
Dangerous to give me an opportunity, but just 3 observations, if I may, Cabinet Secretary, from our perspective, and again, it's born from our very deeply rural context, really. I'm always very conscious that within the Social Services and Wellbeing Act, the fabulous, groundbreaking What Matters principle lands very differently in a very deeply rural context like Powys. We are laser focused on what matters to people, what matters to patients. It drives and shapes our discussions and our decisions. But the minutitude of change in a hamlet, in a village, or in a market town is a big change. And so we need to co-produce services and co-produce our way into the future in a very, very different way. So we are very, very careful that our community engagement, our partnership with people and with communities is centre stage. And I just wanted to give a flavour of that. And that, again, I mentioned in my opening remarks, our context shapes everything we do and the way in which we do it. I also want to reiterate our enthusiastic appetite for being a trailblazer for person-centred primary community rural care. And we've said with prevention, population health at its heart. We talked a lot about our Better Together programme, and I wanted to give you an assurance that in our integrated plan for 26-27, you will see what that means, and you will also see the timeline. So in questions as to what is it and when will it happen, that will become clear within our 26-27 submission. We haven't talked about estate in this conversation. I think it's important for me just to mention that. You'll be aware that we have the oldest estate in Wales. 31% of our buildings predate the NHS, and only 5% were provided or built post 2005. And that linked with, underinvestment over the years, we have a £70 million backlog of maintenance. And so that places constraints on us, which I think are, if you like, distinctive for us as a health board comparatively. And we had an internal audit report in 2024 that gave us limited assurance around the condition of our estate. So we're really keen. So that's why the North Powys programme, as we call it, the provision of the new health and wellbeing hub in Newtown is so important to us and so centrally key to taking forward the Better Together and the transformation programme. And my penultimate point is that we absolutely welcome the opportunity to work closely with yourselves on matters that, yes, affect us on a local level, but also have a national and an all Wales dimension and need that approach. And I know that issues around cross-border commissioning and so on, that we're in those discussions together. And I just wanted to express appreciation for that and say that that partnership and that cooperation is something that we're very grateful for. And my very last point is to end where I began, really, to say we've acknowledged the 30% of our absences that are off because of stress and so on. Our staff do operate, as they do across the whole of the NHS, under the pressure of increasing and arguably relentless demand. But we are extremely proud of the care that they give day in, day out. It is something in which we rejoice continually. And I just want to put that on the public record, and from all of us, I'm sure, in this room, to say a big thank you.
Well, diolch yn fawr, Carl, a diolch chi a Hayley a'r tîm am ddod heddi. Thank you all for the time that you've spent with us today. And we would certainly echo the point that you just made about the work of your staff and thank them as well. And just to convey the message that the discussion in a meeting like this is necessarily focused on things which we want to see more of or less of, depending on the issue, rather than some of the things which we celebrate. That's just inherent, I'm afraid, in this kind of meeting. But absolutely to acknowledge the point that you've just made, which is very, very important. Three takeouts, I think, from me. Firstly, the need to get back on track from the financial point of view, which we discussed earlier. Secondly, the conversation around, I think, the opportunity to become an exemplar commissioner, really given the particular characteristics of the health board and the work around using all the levers that you have at your disposal and getting the access to the information and the data that you need to be able to assure yourselves. And then thirdly, I think, a real opportunity for the health board to help lead, again, in other parts of Wales around the community by design agenda. You've got particular challenges, but also particular assets in that space. And I think really you could be showing other parts of Wales what that really looks like in a distributed model, which is the one that you have to deliver given your geography. So keen to see the progress that you'll make in all those three areas and in others that we've touched on today. Diolch yn fawr iawn.
Thank you.
Yeah. Thank you.